will move down to Dr. Jacques Busquet from Paris, France, and he'll be talking about in-stent restenosis in the carotid. And Dr. Busquet, again, doesn't need any introduction, well-known vascular surgeon internationally, and he has been on the faculty and probably a course director for APVIC for more than 10 years.
I'm very happy to come back to you. I changed the location in a very nice brasserie in Paris to be with you today. How to treat an carotid in-stent stenosis, restenosis. The definition of this kind of restenosis is 70% of restenosis of the inner diameter. This is a rate of 5 to 12% during all the cases. And the optimal management remain unknown, as some people say. The gold standard in France, in Europe, maybe in the world, is still the carotid endarterectomy. A little bit less than 20,000 annual procedure a year in France. And we are trained for that in France. The surgeons are well trained for carotid endarterectomy. But Klaus Matthias, as you know, from Münster and I in Hamburg, did the first carotid angioplasty and the first carotid stenting. It was a revolution for a surgeon, but we want to follow this advance because one French used a Straker stent in the balloon cerebral protection. It was Jacques, now retired, in Khanna. So we had a sort of a group of people working on it in France. My friend, your friend, my colleague, and in a way my mentor, the respected Clifford Berkeley, say in any case, you need a discussion with a vascular surgeon in particular. It was the condition that he gave to the people doing this kind of technique. As you know, we have some authorized stent in carotid with neuroprotection system, and Michel Henry will speak about that later on. We need a very good intervention suite. If not, you don't do that because you need a cerebral angioplasty at the end and also a very good definition of the image with a digital angiography operator controlled. By the way, more you do, better you are. This is a logic in our work. So don't start a program if you do only 10 a year. You have to be good and doing enough, 200 at least a year. Some example, I did this case a few years ago. It was a long eccentric symptomatic stenosis, and look, the control in the midterm follow-up, was it an intimal hyperplasia or restenosis? As you see, there is something around the wall of the stent, probably the start of a restenosis. In fact, which are the predictors? This is very important. It occurs preferentially during the first year of follow-up on a diabetic patient, smoker, sometimes with neoplasm or leukemia. And when there is a residual stenosis from the previous operation, with a small post-procedural stent diameter. Be careful to that when you operate. And when you, I don't know why, you put multiple stents, which is a danger. There is two different strategic therapeutical options, endovascular or surgical. Anyway, do a multidisciplinary decision-making considering the specialty involved in the initial procedure. What are the endovascular options? Restenting is not a solution. Reballooning, maybe. Drug-eluting balloon, why not? Drug-eluting stent, in any case, it will be a self-expanding stent, or the newcomer mesh cover stent, Rod Saver or Sigard. We have to see what they give in the future. Or more classically, you have surgical management of carotid in-stent restenosis. You have to do on operation, a stent extraction, an endarterectomy, or a carotid bypass. Let me present you this case report. A young male smoker, heavy smoker. He had a leukemia, hypertension, and serial pneumothorax. Look to the initial lesion. We decide to put a lateral luminal stent on this distal common, just before the bifurcation of the right carotid. 8 months later, postcards appear a very tight stenosis, restenosis, all along the stent. And I did an angiography showing a severe in-stent restenosis. And we take an immediate decision. It was surgical decision, too complex to go inside in endovascular. Look to the stent inside the artery. We extract it, look inside. There is a neointimal hyperplasia with advanced smooth cell proliferation, obstructing the quasi-totality of the stent. All along the stent, the restenosis. So we perform a normal endarterectomy after stent extraction. Look what we put off. We finish by a Dacron patch to have a good diameter. And as a remember, it was a team approach. This person was controlled, and look, it's him, the patient. The echo Doppler scan is good, widely open, reopen artery. At 6 months follow-up, and a very happy team. The angiologist and the surgeon surrounding the patient. What a nice image. Conclusion. Don't forget the quality of screening with a multidisciplinary approach, concerted decision-making with all specialties, do a regular medical follow-up, don't hesitate to do early re-intervention, and anyway, a risk factor control. I thank you for your attention and very honored to be with you today. Thank you very much.
Dr. Busquet, that was indeed a very good case. I have never seen a restenosis and a neointimal hyperplasia like this. It was almost like a bullet, stent loaded like a bullet. And many a times we have to be clear and humble and understand that not every case is in the domain of endovascular treatment. And actually, it reminds me of what Dr. Buckler used to say. It has to be a combined approach, a team approach, and whatever is the best for the patient, we must do. I would like to have thoughts of Dr. Hirmat and Dr. Tulio also, and Dr. Michel.
Thank you, Dr. Khanna.
Yeah, I would feel if you have an issue with deployed stents, the recurrent options like coronary, I think it took many, many years to finally formulate a strategy, though across the globe, people find different strategies to stabilize an ISR. While here we heard from Dr. How we can stabilize this kind of case, and probably surgery looks a simpler option.